Hello, good day to you. My name is Afam Ej Charles Jr. and I'm still taking in for patient and family care study. Last time we looked at Module 2. Module 2 is analysis of data, and we identified health problems and generated nursing diagnosis from them. We have assessed the patient in Module 1, and we have identified health problems and now have nursing diagnosis. So today we'll be looking at Module 3. Module 3 discusses planning of care, the care that you are going to give to the patient, how you are going to plan it. So as you can see, Module 3, planning for patient and family care study. It involves the setting of the patient or family care objective and outcome criteria. So planning in itself has a lot of components. We'll be looking at it as we move on. This should tally with the nursing diagnosis stated in Chapter 2. So what I mean with this statement is that when point 1 for health problem should match point 1 of strength, as you did in Chapter 2, and for the nursing diagnosis as well. The same goes for the planning or the objective and outcome criteria. So point 1 should match your point 1 for all three, for the nursing problems, for the patient strengths, and also the diagnosis. It should match the outcome and objective criteria. So planning, additionally, it must correspond with objectives and outcome criteria stated in the care plan. So that's what I just explained. So Chapter 3 consists basically of objective and outcome criteria and care plan. These are the two major headings under Module 3 or Chapter 3. So this is an illustration of how a care plan should look like. The first box has the date and time. The second column has the nursing diagnosis. The third column has the objective and outcome criteria. The fourth column has the nursing orders. The fifth column has nursing interventions. Sixth has date and time for the evaluation. The seventh has the evaluation, and the last box, or the eighth box, has the signature. So as we go on, I'm going to explain how you are going to fill each row of every column. So with the date and time, you realize that there were two date and time tables, two columns for date and time. I will be explaining both of them. So for the first box, the first box for date and time is exactly when you identified a particular problem and not when you were drawing the care plan. What I mean by this is, let's say you have a patient, you assess the patient, and you realize that you identify a problem, which is, let's say, self-care needs. Patient cannot perform his self-care needs, as in bathing, brushing his teeth, grooming himself or herself. You have identified this problem. You identified it on, let's say, the 20th of May, 2020 at 10 a.m. So in identifying this, that is the date you are going to state there, 20th of May, 2020 at 10 a.m. That is for it. So the second date also addresses the time frame of the objective set, and is usually assessed an hour before the time runs out. So let's say if you stated in your objective and outcome criteria that patient will be able to maintain his self-care needs within 24 hours, then you can say that the second objective would be, you would evaluate that on the 21st of May 2020 at 9 a.m. So that is it in its simplicity. So we move on to certain objectives and outcome criteria. This refers to the expected outcome of the nurses hope to achieve after caring for the patient. And in certain objective and outcome criteria, it's supposed to be SMART, just like any objective you know. Same applies in research methods. So S for specific. So the objective must be specific. It must be measurable. A for attainable or achievable. R for realistic. And T for time bound. It must be so. If not, you end up doing what we call amendment of care. Because if your objective is not specific, if it's too broad, you might end up not achieving your goal. Your goal might be partially achieved or not achieved at all. So it has to be specific to the problem that you identify. So establishing priorities. This means to categorize the objective and care in various levels in order of importance and urgency. We classify priorities under high priority, medium priority problems, and low priority problems. These are three. This is only to help you in prioritizing which problem is emergent so that you can tackle those ones. Because if you have, let's say, a patient bleeding or a patient who is dyspneic, and you also have wound dressing, which is also a problem, you would have to address the dyspnea and the bleeding first before you think about the wound dressing. Or if a patient has anorexia, you would definitely address bleeding problems and dyspnea problems before anorexia. So that is what I mean by prioritizing. So we move on to high priority problems. These are those which are life-threatening and require immediate attention and are of utmost importance to the patient. So for example, when a patient is dyspneic or is bleeding, patients will be deprived of oxygen to the vital organs and may cause death. So when you are dyspneic and we check your SpO2, as you do on the ward, you realize that patient SpO2 begins to fall. That's the saturation point of oxygen. That's the meaning of SpO2. It begins to fall, and you realize that and it's graded in percentage, so 100%, or between below 90, then it becomes an emergency. It's dropping really fast, and you need to give prescribed oxygen and also give bronchodilators or anything that would help relieve or help patients breathe. So if you have this, the brain and the heart and other organs will be deprived of oxygen. So it's high priority, and this will lead to death. Similarly, in bleeding, when you start to bleed, you lose a lot of blood, and you might end up going into hemorrhagic shock if the bleeding is not arrested. So these examples are high priority problems, and they have to be dealt with first before you look at medium priority problems and low priority problems. So moving on to medium problems. Medium care and goals relate to any unhealthy experience that may result in serious consequences but does not threaten life immediately. So medium problems can become high priority over time. So the example I gave earlier, comparing bleeding to wound and anorexia. So for instance, when you take a wound, a patient with a wound, and the wound is neglected and not dressed, you end up becoming infected. Sepsis will set in, it will become necrosed, and you might end up cutting the affected part off, or causing generalized infection all over the body, which can also lead to death if not managed. Similarly goes for anorexia. If patient is left and hungry and the satiety level is not maintained, you end up causing the sugar levels will run down, and when the sugar levels run down, the patient will go into what we call hypoglycemia, and that will also cause serious life-threatening problems for the patient. So moving on to low priority goals. These are problems that are easily resolved with minimal interventions and little potential of causing dysfunction. So these ones are not that emergent, but even though they are low priority goals, you should address them. So That is for establishing priorities. So moving on to continuing with objective and outcome criteria. They are set in a positive way and are normally has two measurable statements, i.e. point A and point B. So what we mean is when you have your nursing diagnosis, for example, self-care deficit related to general body weakness. That is an example of a nursing diagnosis. You have this nursing diagnosis. So you are setting your objective in a positive way. So you say you have self-care deficit, but in setting it, it then becomes patient's self-care needs will be maintained for, let's say, 48 hours or 72 hours, depending on what the cause is. So general body weakness and the condition relates. So you do your assessment, you look at the patient's condition, you look at the patient's strengths before you set all these objectives. That's why you did all this in chapter 2. So this gives you a fair idea of what you are dealing with. So another example is patient breathing pattern will improve within 24 hours as evidenced by. Then the measurability sets in. Nurse observing patient breathing effortlessly with normal ranges of 16 to 24 cycles per minute. And also B, patient verbalizing that he can breathe well. So these are classic examples of objective and outcome criteria. This is another one for you. Patients will have normal fluid volume throughout the period of hospitalization as evidenced by. So when you look at the components of the objective and outcome criteria, you can see that all the characteristics are there. All the characteristics are there. It's specific because we are saying that patients will have normal fluid volume level. So it's specific to dehydration. When you're looking at dehydration, so you are trying to maintain fluid volume level. So throughout hospitalization, that's it. It's time bound. So for the period of hospitalization, patients will have normal fluid volume. It's time bound. It's specific. Then it's also realistic. You can see from there it's realistic and it can be achieved because it's realistic and it's attainable as well. Then we move to the measurability. Nurse observing patient has moist skin and mucous membranes. And B, patient observed to maintain good skin texture. So it has all the components there. It's specific, it's measurable, it's attainable, achievable, it's realistic, and it's time bound. So my objective here is SMART, and so should yours. So moving on to a third example, patient skin integrity will be maintained or restored within 10 days, as evidenced by A, nurse observing wound to be clean and dry, and wound dressing, healing by first intention. This also has all the characteristics. It's SMART and can be achieved. So moving on to the third box, and in the third box. So nursing orders are stated in command form, and it is ranged in order of sequence. So what we mean is your nursing orders should follow. I will be giving you an example of what I mean in my next slide. And the number of nursing orders should be between 4 and 5. So at least you don't have 4 nursing orders or 4 commands. And they should be specific to the problems. Many times you see students or nurses writing nursing orders which do not apply in the case of the problem identified. You have to be specific, really specific. We try as much as possible to be specific to the health problem identified. You realize that there are general nursing orders. Some of the general nursing orders are fine. When you have it in your work, it's okay. But if you have specific ones, you are at an advantage than those who have general nursing orders. So this is an example. So reassure patients of competent nursing care and staff. This is specific in the case of a breathing problem. It's not specific, sorry. It's general. because reassurance is specific in anxiety. Reassurance is specific in anxiety, but not specific in breathing. But reassuring a patient goes a long way in helping the patient become calm, as in when patient is dyspneic and cannot breathe. Reassurance can put the patient in a calm state to help you implement your other orders. So reassurance is good here. So you assess the patient's breathing pattern. How do you assess that? You've been taught in basic nursing by checking the movement of the chest or the diaphragm, and you count, or using the SpO2 machine, the pulse oximeter, to check all that. You can check breathing pattern. Then you encourage patients to cough up secretions. That is, if the breathing pattern is caused by filled fluid in the lungs or in the respiratory tract, you encourage patients to cough up secretions. Then you administer prescribed medications. Prescribed medications like bronchodilators. So when you give bronchodilators, that will open up the lungs and help the lungs expand and help patient breathe effortlessly. You can also give prescribed oxygen. And oxygen is given depending on as to how the patient is breathing. So oxygen is graded from 0 to 15. So you can give from 0 to 15 liters. And every oxygen flow rate and its delivery device. So from 1 to 6 is for the nasal pons, and from above 6 to 15, you can use the rebreather max, the rebreather phase max, to give effective flow. Because when you end up using the nasal pons to give, let's say 15 liters of oxygen, you end up, because the delivery device isn't appropriate, the patient ends up breathing in carbon dioxide, which will end up becoming a problem for the patient. So when you're also giving prescribed oxygen, you have to look out for the correct delivery device. Moving on to nursing interventions. So you have written your date and time, you've done your nursing orders, nursing diagnosis, you have your objective and outcome criteria, you've given your nursing orders. Now we are moving to nursing interventions. So this refers to actual provision of nursing care, which requires competence in the technical, interpersonal, and cognitive skill dimension of nursing care. At this stage, all the planned care and nursing actions are executed as appropriate. So we are trying to execute the nursing orders which we have come up with. So let's say we have said that we are going to reassure the patient of competent health care. So that is what we are coming to do in the intervention. We've said that we are going to give prescribed medications, that is bronchodilators. So we'll write the specific bronchodilator that we are going to serve. Moving on. So with nursing interventions, the care rendered should be documented with specific characteristics. So what we mean here is, if you say you are going to reassure the patient, we want to know exactly what you are reassuring patients of. If you say you are going to give prescribed medication or prescribed bronchodilators, we want to know the specific bronchodilator that you are giving. So I have an example there. So you can say that you give 300 ml. So the order can be serve patient food in bits. Serve food attractively and in bits. So in your nursing intervention, it then becomes 300 ml of Milo drink served and well tolerated, instead of breakfast served, which doesn't have any characteristics. Saying breakfast served, you have intervened, but we want to know the specific breakfast that you served. That is what we mean by specificity. So lastly, you would have evaluation. But before that, you would have date and time in the box, which I've already explained. The second date and time, which we'll be looking at the evaluation date, when you are going to evaluate. So with evaluation itself, it is where a value judgment is placed on the outcome of care. It includes conclusion drawn by the nurse and patient on whether care has been effective in meeting the set objectives. That's why in objective or outcome criteria, you realize that the measurabilities are normally two. One speaks for the nurse, and mostly the other speaks for the patient. So we try to find out whether both parties are satisfied with the caregiving. Then we can evaluate to say that if the goal was fully met, partially met, or not met. So to do this, the patient is reassessed in relation to the first assessment. Then the care is compared with the problems identified and planned. Patient's responses will then be compared with patient's previous condition to determine any change in patient's health status. Then the responses will then be compared with specific objectives to see whether they have been met. Evaluation is drawn stating whether the objectives are fully met, partially met, or achieved, with explanations, or not achieved at all. So if your goal is partially met, you have to give reasons why it was partially met. So let me give you a typical example. You have identified a problem as patient having a wound. So you have a definite time of identifying this problem. You state that time. Then the nursing diagnosis becomes impaired skin integrity related to surgical incision. So a patient has gone for surgery and has a wound. It becomes a problem if we do not dress the wound. That is the problem. So we've stated a time, we've stated a nursing diagnosis, and now we have to set a SMART objective. So in setting a SMART objective, we will say that patient's skin integrity will be maintained throughout hospitalization or within, so depending on the wound, within 5 days, as evidenced by patient's wound looking clean and dry, patient's wound being free from infection, patient's wound healing by first intention. These are all measurability statements that you can use. But in a case where you use, for example, patient's wound healing by first intention, then after you're about to evaluate, you realize that patient's wound was free from infection and patient's wound was clean and dry, but had not healed by first intention. Then you cannot say that goal was fully met. Because if you have patient's wound healing by first intention as part of your measurability statements, you cannot say that goal was fully met if it doesn't heal by first intention. Then it becomes partially met. Then you have to state reasons why the wound did not heal by first intention. Maybe the wound dressing wasn't done well, or patient didn't take his antibiotics, or patient wasn't eating diets rich in nutrients that will help heal the wound. You know that you have to state for us to know. And when evaluation is done and it is realized that goals are not met or partially met, we do what we call amendment of care. So if goals are not met or achieved, care is terminated. If goals are met and achieved, care is terminated. So once the goal is fully met, you see no need to do an amendment of care. All you need to do is to terminate the care, and we know that patient is doing well for that problem. However, if goals are not met or achieved, or partially met or achieved, then the objective and care will be modified or amended to continue for another period. So, the example I gave earlier, you have a measurability of wound healing by first intention. Then, at your evaluation point, you realize that the wound has not healed by first intention. Then you have to reassess and do what we call amendment of care. Amendment of care is redoing the nursing care plan. but re-evaluating it. So you now have to come up with a realistic, a smart objective that can be achieved looking at the wound, or you have to come up with new techniques that will help you achieve this goal. Evaluation is written in the past tense. Therefore, the measurability statements of the objective and outcome criteria are written as such. So what we mean is that you have set your objective and outcome criteria. You have said that patient's wound will be maintained, patient's skin integrity will be maintained throughout hospitalization, as evidenced by patient's wound looking clean and dry, patient's wound having no signs of infection, and patient's wound healing by first intention. So when you come to the evaluation, you then have to write the measurability statements in the past tense. So making it goal fully met as A, patient's wound looked clean and dry. B, patient's wound had no signs of infection. C, patient's wound healed by first intention. Then your evaluation becomes correct. So moving on, these are some examples of how the evaluation statement is to be written. So goal partially met as respiratory rate was recorded as 25 to 30 cycles per minute, and patient said he felt slightly better. In the objective and outcome criteria, we said previously that patients having respiratory rate between 16 to 24 cycles per minute. But you realize that here, patient recorded ranges between 25 to 30 cycles per minute, making it higher than the expected rate. So it was partially met because patient also said that he felt better, slightly better. So we have to, in this case, we have to reassess patient breathing pattern, or we have to reassess patient breathing and do an amendment of care. Another example is goal fully met as patient's fluid volume was maintained throughout hospitalization. So in this case, you do not need to re-evaluate or redo an amendment of care because the goal was fully met. So at this point, you just terminate. A third one is goal not met as patient's wound did not heal by first intention. So in this case as well, you'd have to do an amendment of care, reassess why patient's wound did not heal, and make a smart objective to deal with the problem. Then finally, we'll come to signature. With the signature, you can either use a digital signature or type in your initials in the space created. So you realize that you have 8 columns, and the last column is for the signature. So for the signature part, you would put in a digital signature, as in a scanned signature of yourself, or you put in your initials. Your initials can be KLM, as written there. And in drawing the nursing care plan, it has to be in landscape. It makes it easier to go on the page, and it helps to do it effectively. So we've come to the end of Model 3. It has been an exciting time with you. My name remains Afam A.J. Charles Jr., and thank you for your attention.